Hello, my dear students. I sincerely hope for your good health and everything is going good back home. Uh, we started our discussion on to the medical mycology, and we started with the first important genre, that is the persistic. The persistic fungi, they cause disease in immunocompromised individuals, whereas if you look at that, they do not cause disease in the immunocompetent individuals. And the four important genera of a persistic mycotic organism, they were the Candida, Cryptococcus, Aspergillus, and Mucor, etc. And we were on to this slide when last we finished with this, and we were discussing the chromogenic media. And this is what we have, the four important species of the Candida. The Candida albicans, Candida tropicalis, Candida parasilosis, and Candida glabrata. Now, these four species, they give different color on the chrome Candida agar. The species of the Candida albicans, they will look green in color, whereas the Candida tropicalis, they will look, you see, the blue in color, and the species of Candida parasilosis would be white in color, and glabrata would be the pink in color. So this is a medium which is used for the identification of these four species of the Candida genus. As we all know that Candida, they are the important organism, and they causes thrush, vaginitis, uh, diaper rashes, chronic mucocutaneous candidiasis, along with that of esophagitis. And they also cause the disseminated right-sided endocarditis, particularly in the individual who are especially use of drug. The drug users there also. It also causes, you see, the candidemia, which is the infection of the bloodstream, along with that of the endophthalmitis, which is the infection of the eye. Now, if you look at the various properties and of the species, they are the oval yeast with single buds and the normal flow of the mucous membrane and respiratory tract and the vaginal tract. And they occur as a yeast, and they also form the pseudohyphae. And they really are they're not the real hyphae, but they form a pseudohyphae. Now, with reference to the transmission of the disease, as we all know that they being the member of an normal flora and being already present in the mucous membrane and skin area. Now, in addition to this, the Candida albicans, they are also present throughout the gastrointestinal tract, and they're especially in the area of mouth and esophagus. The genital tract, the seed is full of Candida albicans, and it causes thrush, which is, you see, the pseudomembranes which are formed by the species of the Candida albicans. The birth canal, it is heavily contaminated with the Candida albicans. And the newly born baby, during the process of parturition or delivery, it gets infections like we have seen in case of Nexidium ningitis. So the organism is normal flora in the mucous membrane, respiratory tract, GI tract, and it causes thrush in the newly born babies. Now, the presence of this organism on the skin, it predisposes us to the infections involving these tumors. Whenever there is a breach in the mucous membrane or in the skin, because of some intravenous devices in placement or catheterization or urinary catheterization, the individuals, they are exposed to this infection. So the pathogenesis of the disease is very important, and the clinical signs are very, very characteristic. Now, the first line of defense in case of Candida albicans infection is the intact skin and the mucous membrane. As you have seen that the intact skin and the mucous membranes, the penetration, these two barriers, they really provide the opportunity for the yeast cells to enter into that. So the first line of defense is the intact skin and the mucous membrane. And of course, you see the organism, it can be seen in the individuals who are having the cell-mediated deficiency. So this means that the cell-mediated immune response is the second line of defense, and the individual who are having neutropenia, they are also have been proven to be the predisposing factor for this infection. So what happens when there is a local or systemic infection, or there is host impairment of the immunity, this causes the organism to enter into and result into the overgrowth in the mouth, and where it produces the white patches, and these are the pseudomembranes, what we call as the thrush. Now, the organism can also cause vulvovaginitis because of the itching and the discharge is in favor of with this organism. And this vulvovaginitis is favored by the high pH, and the diabetic individuals, they are more prone to, and individuals who are on the antimicrobial chemotherapy, because the lactobacilli, which are the normal flora in the vagina and the vulva, they really have to maintain the low pH of the area that protected from the infection, the commensals infection or the normal flora infection. Now, when there is a change in the pH goes high, or when there is use of antimicrobial drug, that kills the lactobacilli, and this provides the probability that the pH it goes high, and that favors the growth of the Candida albicans. The skin and veins, particularly in the warm and moist areas, and it becomes red, it becomes weepy. Now, the fingers and the nails, can also be involved, and particularly in those individuals who repeatedly immerse their hands in water, particularly the individuals working in the restaurants and they are dealing with the dishwashings. There is, of course, the thickness or loss of the nails. The diaperiasis in infants, they can also be seen if you see the diapers, they're not changes well in time. If we do not change the diapers, the wet diapers, if they're not changed well in time in the babies, and they persist for a little longer period of time, it results into rashes. So starting from, you see the vulvovaginitis and the involvement of the nails and the loss of the nails, the diapers, they can all happen in the infection with the Candida albicans. Now, the immunosuppressed individuals, they are more prone to this infection, as we have already seen. And Candida in the immunosuppressed individual, it can result into dissemination of this organism into many organs, and it can cause what you call as the chronic mucocutaneous candidiasis. Chronic mucocutaneous candidiasis, what is CMC. It's a prolonged infection of the oral and the skin or the genital mucosa, and the nail also. And the individual, it is deficient in T-cell immunity, and they're prone to this infection. Now, the intravenous drug abusers and those who are experiencing the indwelling intravenous catheters in the hospital setup, they predispose to the systemic infection. And Candida albicans, it particularly causes right-side endocarditis in patient. There is esophagitis, which is accompanied by the involvement of the stomach, because the infection, it travels downwards from out to the stomach and then to the small intestine. And this is particularly seen in patients who are dealing with the lymphoma, or who are suffering from the leukemia or lymphomas. The subcutaneous nodules, they can also be seen in the neutropenic individuals with disseminated disease. So the neutropenia, it predisposes to this infection. The most common species to cause disseminated disease is the Candida albicans. But Candida tropicalis and Candida parasilosis, they are also important pathogens, and they can also cause these kind of diseases. Now, this is how you see the endophthalmitis appears. There is disseminated candidiasis, and the Candida organism, it lodges in the eye area, and it leads to the endophthalmitis, which is a disease caused by the Candida albicans. Disseminated candidiasis in the form of endophthalmitis caused by Candida albicans species. Now, we can see here, you see the stuffing of the nails, and to some extent, the disfiguration of the fingers. These are the granulomatous lesions. The granulomatous lesions, this is again the end result of the systemic fungal infections of Candida albicans. this, you see a very, very important view of the, what you can see, the sloughing of the nails, and there is to some extent the disfiguration of the fingers. Again, you see we are really, it's the images from the courtesy where the Dr. Fungus eye. Now the laboratory diagnosis is based on to the, what you call as the exudate or tissues. Now we can identify the budding yeast with the pseudohyphae if we really stain the organism with the gram stain procedures. But they can be valorized using another stain, what we call the calcifer white staining. The organism can be grown onto the culture, and we can find or see the typical yeast colonies because it's dimarker fungi. In the room temperature, it appears as yeast. In the body temperature, it appears as hyphae. So in the room temperature where the media they are placed, they're typical yeast colonies, and they really look like or resemble with that of the large colonies of the Staphylococcus aureus. We can perform another test in case of meningitis caused by Candida albicans, that if you really want to differentiate or look into that whether the cause of meningitis is Candida albicans, we can take the serum and we can incubate that for 2 to 3 hours, and there will be a germ tube appearance and at 37 degrees centigrade. We'll see you, we'll let you know that how it is appearing. The calamitous spores, they are typically formed, but not by the other species of the Candida. So these two, you see the appearance of the yeast colonies on the Sabouraud agar, and even to some extent it can grow into blood agar also. And the visualization of the germ tubes and the serum. They are the tests which are used for the lab diagnosis of Candida albicans infection. We can also have the serological testing, but it's very helpful. This test, the colonies and the germ tube test are the real helping test in the diagnosis of Candida albicans. Now, this is how the colonies of Candida albicans they appears on the Sabouraud glucose agar at 27, Sabouraud agar at 25 degrees centigrade. You can really see the very discrete, isolated colonies of white in color. They resembles to the colonies of the Staphylococcus aureus. So, but they're white in color. Remember, they're white in color. The colonies of Staphylococcus aureus, they are golden in colors. They're so a little bit smaller in size. They're not that whitish in appearance as it's seen in case of Candida albicans. And moreover, you see the colonies of Staph aureus, they are more visualizable in the blood agar compared to that of the colonies of the Candida albicans that we see in the Sabouraud agar. Now, this is a very unique picture, and that we can see what we call as the screening test for the identification of Candida albicans. I'm sorry for that. Now, you see, there is production of the germ tube. This is how you can see. Germ tube of Candida albicans. You take the serum specimen or the plasma of the patient with meningitis suspected of having Candida infections. So, Candida albicans and meningitis, you can take the serum or the plasma and you incubate it at 37 degrees centigrade for 2 to 3 hours. No, we do not need anything. And then you can see the germ tubes. These are germ tubes. The germ tubes. These cells, germ tube cells. Germ tube cells. Very characteristic and pathognomonic. This is the specialized stain. Specialized stain has been used in order to see this microorganism. Please do not forget the PIS pictures, because sometimes you do get these kind of pictures in the auspice and the scenarios like this in the MCQ examination of the probe or setups, right? Now, the germ tube test, this is you can see the negative germ tube test. Candida albicans species are there, but there is no production of the germ tubes. There is no production of the germ tubes in the plasma after 3 hours incubation time. So we can have the budding blastoconidia only seen budding cells. We can see the budding cells. You can see the budding cells over here. The major cell, the budding cells. But there is no germ tube. So you can very well compare both of these slides having same staining process. One with the germ tube, other without the germ tube. The germ tube test is positive in case of Candida albicans infections and meningitis. It's again positive in case of negative in case of meningitis. In case of if there is no Candida albicans infections. So the isolation of the organism or the growth of the Candida albicans species on the Sabouraud agar along with that of the germ tube test, are the two mainly used lab diagnostic procedures for the Candida albicans. Now, the treatment and prevention, as we have seen in the very first lecture, the generalized line of treatment, the fluconazole for the oropharyngeal or phageal thrush, the caspofungin or other drug can also be used for this purpose. The skin infections can be used, can be treated with the topical antifungal drug, mostly the clotrimazole and nystatin. Mycology2 Candidiasis by ketoconazole, and we can also use it for the disseminated or systemic infection, the amphotericin B or with that the fluconazole. A combination can also be given. You see, the fluconazole useful in high-risk patient is very useful. Those undergoing bone marrow transplantation, they really require this kind of treatment because of the reduced cell-mediated immune response. They are more prone to the they're more predisposed to the infection of the Candida albicans. So Candida albicans infections in high-risk patients must be avoided by the use of fluconazole. That was all about the Candida albicans. Now we move on to another very important organism. Again, the opportunistic pathogen, and the organism is the Cryptococcus neoformans. Cryptococcus neoformans, it causes diseases, what we call as the Cryptococcosis, and especially the cryptococcal meningitis, which is the most common life-threatening fungal infection in AIDS patient, autoimmune disease syndrome. The individual who are suffering from AIDS, and they are more prone to the cryptococcal meningitis, and this infection result into a life-threatening situation for these individuals. Particularly, you see, we can see the most common life-threatening infections, and there is another species of Cryptococcus neoformans, which is known as Cryptococcus gattii, G-A-T-T-I, and it has also been seen, but with less frequency in AIDS individual. Now, the cryptococcal neoforman is a yeast which is an oval in shape. It again is a budding yeast, and it is surrounded by a wide polysaccharide capsule. If you remember that in the very first lectures, I told you that all organisms can be identified as capsule-forming organism. There was one fungus, that was the Cryptococcus neoforman. It has a very big capsule, which is made up of polysaccharide. This fungus, which is again a persistent fungus, but it, unlike the Candida albicans, it does not enter into dimorphism. It occurs just in one form. It occurs in the yeast form. There is no hyphae form. It does not. So the form is a narrow-based bud. This yeast, the fungus Cryptococcus neoformans, it forms a narrow-based bud. The budding is from the narrow base. Whereas the yeast of the another important fungus, Blastomyces dermatidis, it forms a broad-based bud. So we can distinguish both of these fungal cells based on to their budding. If the cell is budding having a broad base, it is Blastomyces. Blastomyces buds from broad base. The Cryptococcus neoforman, it buds from a narrow base. And these are this is the area where we can really target for the identification of two different cells of Blastomyces and the Cryptococcus. Here you can see you can see the encapsulated yeast, and this is an in preparation. This means the yeast cells has not been stained. The yeast cells have not been stained, but the periphery or the margins of the capsule has been you see the stain. This is starting from here till here. This is all capsule. This you can see the big capsule of the Cryptococcus neoformans. This is the unstained area is the yeast. This is the yeast. So the small round structure in the center of is white in color almost. I'm sorry. This is the yeast, and this is the huge capsule that we can see in case of yeast cells. So based on to the staining with the iodine stain or with the India ink stain, we can really visualize the big capsule of the Cryptococcus neoformans. and this helps us to diagnose the fungus. Now, the transmission of this organism, the Cryptococcus neoformans, it is widely distributed in the nature and grow abundantly in the soil that contains birds. Particularly, you see the pigeon droppings, especially the pigeon droppings. Those individuals who are, you see, very fond of having pigeon raising, जिनको हम कहते हैं कि ये कबूतरबाज हैं बहुत ज़्यादा, they are more prone to this because the organism, it does not cause any harm to the bird. The birds are not infected, but the fungus is in the pigeon droppings. When these droppings they dry, and you see after dryness they become light and they can expose in the air. So the human infection results from the inhalation of the organism which is present in the fungus in the pigeon droppings. There is no human-to-human transmissions, and the Cryptococcus gari, which is associated with the eucalyptus trees, we have very common in this area. Although this is common in the western part of the United States, but we do have the eucalyptus trees, जिनको आप कहते हैं सफेदा का दरख्त बहुत है हमारे पास भी. So they are found typically in the tropical as well as in the subtropical areas of the continents. So again, another important fungus with reference to our area, the regional area. Candida albicans is very common. Cryptococcus neoformans is very common in this area. The pathogenesis of the disease is, see, the lung infection is often initially asymptomatic, but it may produce the pneumonia, and this occurs mainly in patients who have reduced cell-mediated immunity. And again, you see the age of the patients of AIDS. Now, the opportunistic infections, like the opportunistic mycotic infections, I need to say, like the opportunistic fungal, the opportunistic bacterial infections, they are always associated with the individual who have the reduced cell-mediated immune response, who are immunocompromised. Their cell immunity is not fully functional. And because of the diseases, because of the medication, because of surgical procedures, because of the cancer or leukemia or lymphomas, so they are more prone to infection. Now, the organism, it can also disseminate it to the central nervous system, where it causes meningitis, and it can also go to the other organs. So disseminated infection is there. Now, the subcutaneous nodules often are seen in the disseminated disease also. The half of the patient which have the cryptococcal meningitis, they do not show any evidence of immunosuppression. So this means that the immunocompetent even to some extent, the old age individuals, that they can also be affected with this organism, the Cryptococcus neoformans. Now, some AIDS patients which are treated with what we call as the highly active antiretroviral therapy, hard therapy. What we call hard means the highly active antiretroviral therapy. Now, this is a treatment which is heavily used for the AIDS patients. Now, the treatment with this antiviral therapy, it enhances, it accelerates the symptoms of the disease, what we call as the immunoreconstitutional inflammatory syndromes. Now, patients of AIDS treated with hard therapy, they show, you see, the accelerated symptoms, and this condition is referred to be as what we call as this phenomena is known as IRIS phenomena, means that immune reconstitution inflammatory syndrome. Now, what happens? The explanation of this exacerbation or acceleration is that the treatment of the AIDS individual, because of some effect, the individual is recovering, and this recovery is increasing the CD4 cell counts. Now, this increase in the CD4 cell count, it increases the inflammatory response. Now, this inflammatory response has led to the death of some of the patient, and that's why in order to treat this disease, the patient must be treated first with the underlying disease before we move on to the therapy, heart therapy. The Cryptococcus gattii, it also causes a condition what we call as the cryptococcomas. Cryptococcomas are the granulomas. This means that infection can proceed a long period of time, enter into chronic phase, and it will make a granuloma. Like the granuloma is made in case of bacterial disease like tuberculosis. Uh, uh, so it is entered into the granuloma of the brain. The granuloma of the brain is caused by a specialized species of the Cryptococcus, what we call as the Cryptococcus gattii. Now, here you can see the raised scale lesions which have been resulted from the dissemination of the yeast in immunocompromised patients. So, this is how the encapsulated yeast cells in the brain tissues, like the encapsulated yeast cells in the brain tissues, what we call as we have seen that gattii is in the brain also, and this has been stained with the Mucicarmine stain, and you can really imagine the cells in the brain tissue. Again, you see one other microscope view of the Candida neoformans yeast in the lung tissues. This is the gram stains, and you can also see the very, very large capsule area. Now, the laboratory diagnosis of this disease, what we call as the Cryptococcus neoformans or Cryptococcosis, in the spinal fluids, with the India ink, the yeast cells there microscopically can be seen, and we can identify these cells by unstained capsule, and we can also use the gram stains procedures, but that's not reliable. And the organism can also be stained with the what called as the methymine blue stain or periodic acid necromin stains. They really help us in the visualization of the organism. The organism can be cultured from the spinal fluid and from the specimens onto the Sabouraud agars. And colonies, as we have seen with the colonies of the other capsule form microorganism, they are mucoid colonies. Mucoid colonies, and which is the refraction of the large amount of the polysaccharide capsule which is produced. As we all know that the capsule-forming bacteria or fungi, they make mucoid colonies. You can really visualize these colonies and the mucoid appearance of these colonies because of the capsule formation. Here you can see we have the microscopic morphology of the neoformans, and we've seen the encapsulated budding yeast. You see, this is the capsule. This is the capsule over here, and we have the encapsulated budding yeast. Now here you see, the budding is from a narrow base. The budding base is narrow. It's not a broad base like Mycology2CandCrpto. The Cryptococcosis budding yeast, but the buds, they are small budding yeast. So there is no pseudohyphae, as we have seen those in case of Candida albicans. So the budding yeast, the budding is from the broad base. It's not a broad base budding. It's a small base budding, narrow base budding, and there is no hyphae. The laboratory diagnosis we can also have with that of the serological test, which can be done both with the antibodies or with the antigen serological test. In infected CSF, the capsular antigen, it is very high because this organism makes a big capsule. That big capsule antigen is very much prevalent, and the antigen titer is very high in the CFS. This can also be detected with the help of latex particle aggregation test, what we call as the cryptococcal antigen test, a CRAG test. Cryptococcal CR for Cryptococcus, A for antigen, AG for antigen. So CRAG test is used, which is a lattice particle aggregation test for the cryptococcal antigen reaction in the serum. The detection of cryptococcal polysaccharide capsules antigen, the method of choice, and of course in the AIDS patient, this antigen can be detected in the serum only in 100% of the cases. Okay. In AIDS individual, because of the decreased immunity, the cryptococcal antigen can be detected in the serum in almost. In non-AIDS patient, antigen detection in serum is less sensitive, with only 60%. So this, the cryptococcal antigen detection test is highly sensitive, and and highly specific in case of AIDS individual, but it's not that much sensitive or specific in case of non-AIDS individual. This is how the latex test will look like. You have the antigen, you have the serum, you just mix them, and you will have the clumping or agglutination. You can see very well. This is spot test, agglutination test. The treatment of this disease is like that of the other antifungal. It's combination of antifungal drugs as we use in other fungal infections. Combined treatment with amphotericin B and flucitocin in case of meningitis and disseminated diseases. There is no specific means of infection and of prevention except that we have to avoid, inhaling in the area where there is more birds and more droppings and more dry area that causes dryness of the dropping, and in powder form you can inhale that. The fluconazole is used in AIDS patient for a long-term suppression of the cryptococcal meningitis. So in combination of the hard therapy we'll have to use, but keep in mind that there is a phenomenon, what you call the AS phenomenon, that can be triggered on and it can cause death. So we'll have to treat the disease first and then we'll have to go for the disease. That is all about the Cryptococcus, and that is all about for today. Thank you very much. Enjoy your time.